in terms of events in the nation on early in the new year will hopefully proceed and only things get better. We've got Reshma did just an extraordinary job of detailing the minutes from the last meeting, which was also filled with a tremendous amount of information and detail. And so I've reviewed them. I don't see any cause for changes, additions, or deletions. Does anybody else have any discussion points about the minutes? Hearing none, may I hear a motion for approval, please?
So moved.
A second?
I'll second.
Motion's been made, seconded. We'll just do a vote by acclamation unless I hear any negatives or, all right, any abstentions, abstentions, I guess is the word, not abstinence, but abstentions. I've been in Utah too long. Abstinence, public education. All right. As you see, Adam, this meeting is filled with nothing but good humor. All right. So the minutes are passed. Our first item for quick discussion is Rich Oborn. Talk about the legislature. Rich, it's to you.
Yes, good morning, everybody. I'll just be brief. I'm the director of the Center for Medical Cannabis, and I just wanted to introduce just a few items that we know that the legislature plans to introduce during the 2021 session. 2021 session begins next Tuesday, and it lasts for 45 days, as many of you know. And specific to medical cannabis legislation, we expect, as has been mentioned before, but just as a reminder, we expect there to be a bill that will make it so that the medical cannabis product information will appear in the controlled substance database. And that'll be a requirement that the department will have the responsibility to ensure that the software that collects all the medical cannabis product information about each product purchased in the state of Utah, that is uploaded into the controlled substance database. And it'll be its own little piece of the controlled substance database if this bill passes. And there will definitely be a need for some additional funding related to make that happen. But DOPL has been a part of some of those discussions. And right now it is only just a concept, an idea, but we do expect that there will be a bill that will include that provision. And I know that's something that has come up during previous meetings. A second issue that we expect to see is the creation of the limited medical provider, the LMP designation. And I know that some of you have some opinions on this, but what this would do is it makes it possible for any MD, DO, APRN, or PA in the state of Utah. I think there's about 16,000 of those in the state. Any of those, as long as they have a controlled substance license, would be able to recommend medical cannabis to a patient, as long as their number of recommendations is under 15. They could communicate that recommendation to one of the 14 medical cannabis pharmacies licensed by the Department of Health. And then the medical cannabis pharmacy would then register that and help the patient get a medical cannabis card. And then for renewal purposes, that limited medical provider would communicate their support for renewal. And those renewals are every 90 days after the first 90 days, and then every 6 months after that. So that would be a change to the current law. The current law, under the current law, you'd have to be a qualified medical provider that has at least completion of a 4-hour course, and also pays a $100 registration fee in order to recommend medical cannabis. So those are two provisions that we expect to see during the legislative session that relate to medical cannabis. And there's others, but that's all I'll focus on this morning.
Rich, I've got just a couple questions with regards to that. Did anything go further with any information coming out of Senator Vickers or his office with regards to waiving the educational requirement for becoming a qualified provider? I think Dr. Babbitts had communicated a bit about that to me, and we had discussed it and had some communication with the board with regarding whether we needed to have some more formal communication with Senator Vickers about our concerns that this would leave recommenders, if you will, inadequately informed about the scientific issues. Anything you can say further to that?
Yes. So I'll emphasize our recommendation to lawmakers in that respect has been we would like them to modify the current controlled substance training that all prescribers have to do in the state of Utah, that existing course that's administered by DOPL and I think Utah Medical Association helps create that course. We are recommending that be modified such that it just includes some training, and it could be minimal, but some training on medical cannabis treatment and the medical cannabis law. And we felt like that was a good compromise that we have proposed. And it hasn't, I think the initial response from lawmakers was positive about that proposal. And so we're still waiting to hear exactly what they'll include in a bill, but that's at least what we proposed.
When you say we, Rich, who is the we?
Department of Health.
Department of Health. Okay.
Yeah, so between Dr. Babbitts and I, we were trying to figure out something that would be agreeable to lawmakers, and rather than requiring a completely separate course that the providers would have to do, the limited medical providers, we felt like it made sense to incorporate, for lack of a better term, a mini course on medical cannabis into something that already existed. So the existing prescribers, they wouldn't be having to complete a completely separate course. It would be incorporated into something they already have to do. And as we all know, medical cannabis is a controlled substance. So it made sense to incorporate it under our proposal into an existing controlled substance course. Cannabis is, of course, a controlled substance that not a lot of providers have training on specifically, especially training that is recent that will help them understand some of the studies and the indications and contraindications that have been found to be present with cannabis. So that's I think gives you a little more information.
Alrighty, this actually is a topic that I think bears some greater consideration and discussion, which we don't have time for today. So I'm going to recommend, with the board's approval, that we put this on the agenda for either February or March. I don't think it's a pressing matter, but I think it would be good to discuss this with representatives from DOPL, perhaps somebody who believes that less education about this is warranted rather than more, from maybe the legislature as well as from the Utah Medical Association, so we can have a really fully informed and fleshed out discussion. It seems to me, and the reason I say this is that the more we dig in as a board, and which we've done over the course of the last 12, 18 months, and especially over the last, say, 6 months, as we've gone deeper and deeper into the various conditions and indications, one of which we're going to talk about in great depth in just a minute. It seems that people in medical practice, in one area or another, in healthcare practice, really need to know a whole lot more about the implications of cannabis use in one form or another than less. There's a lot of mythology. There's a lot of conflicts of interest from the standpoint of financial gains to be made by people in the industry versus the rather thin, and rather the dearth of clinical knowledge and expertise that exists. And so maybe Rich, you and myself, and maybe Mark and Reshma can have an offline discussion by email over the next week or two and talk about how we might shape this up over for maybe February or March. Just without a prolonged discussion, because I don't want to keep Adam waiting. Any moments of angst or anything that anybody wants to weigh in on that, or think that am I overreacting? Do we, should this be something that we should dig into more or less? Just a quick couple of thoughts.
Ed Red here. I don't know exactly what final form the bills are going to take, but if we're going to have any influence on the outcome of the actual bills, we'll have to do it in the next 4 weeks, because of the process, the legislative process. It ends on March 10th or 11th or something like that. And really things are pretty much done by about the middle of February. Whatever's going to happen is pretty much finished by the middle of February. So if we're going to do anything that's going to influence the bills, we need to stay on top of it. And probably if the Department of Health wants our input or our opinion on that, I think we need to be part of it, in the next 4 weeks. The other issue I have, the Doppel part, I think is really excellent, but I think we need to make sure that whatever information Doppel's putting on the controlled substance database, it has to be, in my mind, it's pretty complicated because there's, having worked a little bit with our local pharmacist who's managing the local, dispensary or pharmacy, cannabis pharmacy, it's just like everything changes month to month, what products they have available, what the makeup of the product is. I mean, even there's no consistency at all. So it might be simpler initially for the first year or two to just say, yeah, this person's got a prescription for cannabis and it's on the controlled substance database. Because I think to start that right off the bat might be really complicated. So hopefully, Richard, you've got the pharmacists and other people participating in the decision making about how to do this. I think it's a great idea. I think that people that are prescribing other medications need to know that somebody's taking cannabis, and I think it's important to do that. But I think we might want to make it more simple, more complicated right off the bat, because right now the controlled substance database, when you do an opioid prescription, it tells you the actual dose, the number of doses, everything, when it's supposed to run out, how many days it's supposed to last, and that might be really complicated in the cannabis world because of the lack of consistency between products, even inside the same pharmacy. So it's really, I don't know. That's just my concern. I just wanted to throw that in there.
Well, yeah. Ed, that's actually a great segue to Dr. Gordon's both his presentation this morning, but also one of the recommendations that, as he provided us information from the American Society of Addiction Medicine, from ASAM, one of the recommendations is that this information is available through controlled substance database and so forth. So I don't know, Adam, I don't want to hold you up, but after your more formal presentation discussion about that, if you've got a few extra minutes to stick around, I might want to circle back to this, because Mark, given the fact that in Ed's comments that the legislature is going to be diving into this really quickly, what say you about any constructive things we may do in the next maybe 2 weeks to bring about our thoughts and help you and the Department of Health with regards to education issues?
Clearly under a great deal of pressure to expand access to medical cannabis for patients. Patients are complaining they can't get in to see people, that it's long waits, and people are charging exorbitant fees to get a medical cannabis card. Thus the idea of you could do 15 of your existing patients if that was a limit of that. When we brought up the idea of education, they were okay with that. They're not against the 4 hours for the QMP, but they talked, well, maybe they'd be willing to allow a little bit, might be able to be added into the controlled substance, like Rich was saying. So it's a question of whether something should be added in at all. I think Ed had a great idea that we probably ought to bring forward. Maybe he'll bring forward to legislators, which is, for the first year or so, just have a notation, the patient's on medical cannabis, period, because he's absolutely right. The variation of doses and formats and totals there's no way you could put it in the way it's currently in the CSD. So that may be a suggestion this board would like to adapt. So I guess the question is whether the board would like to consider meeting, like the end of January, specifically to discuss legislation. Do this board want to have any input, or these two bills, but in terms of cannabis, that may be the thing to do. But from our point of view, we think we're pretty good understanding of why they're doing this. I was not in favor of the LMP, this limited provider. I was against that, and Senator Vickers knows that, but basically saying to me, sorry, we have too much pressure to expand access, so we're not going to keep limiting it to QMPs.
Yeah, it's also interesting, Mark, that that recommendation 8 in the American Society of Addiction Medicine recommendations. These are the experts who think and talk about issues related to potential, at least certainly mental health and substance use harms from cannabis. Their recommendation, at least one of them explicitly states that these sorts of decisions should be fully informed by clinical science and evidence, and not by public initiatives or legislators. And it seems that in some ways we're being a bit, that recommendation is certainly, that was bypassed a long time ago for reasons we all know and understand politically in the state. But this is an opportunity to take a deep breath and maybe provide a little bit more of a pause and thoughtfulness about where things stand. So I would certainly be in favor of us regathering maybe in 2 weeks for an extra session of this board at a time when most of us would be available. I wouldn't be opposed to that, and maybe concretize some of these thoughts. Is there anybody opposed to doing that other than for scheduling reasons, just on principle for some reason? Okay, if not, Reshma, might I ask you to sort of poll folks, and let's see, sometime in the next 10 to 14 days when we might be able to get back together for an hour, and maybe a little bit more discussion from Rich and Mark about, and maybe Ed with your resources and your experience in the state legislature, think about what we could do that might be help thoughtfully move or influence some of this going forward on behalf of the public health, recognizing all this political pressure and social pressure that folks are under. All right. Thanks, Reshma. All right. Without further ado, we really are extraordinarily fortunate to have as our guest presenter today, Dr. Adam Gordon, a physician. There's probably nobody better positioned, not just in the state or the country, but perhaps in the world. And I'm not aggrandizing this, with Adam's qualifications, experience, education, and involvement. I think he can speak to the issues related to cannabis and potential either harms or benefits with regards to, or the evidence with regards to, especially opioid use disorder, better than anybody. And he's in our own backyard. Adam, Dr. Gordon is a Pittsburgh product from medical school through fellowship, and I appreciate the fact, if you are a Pittsburgh Steelers fan, Adam, that you crawled out from under your covers and treated your deep dark depression from the how many turnovers and 28 points in the first quarter. Anyway, a dark day for a Steelers fan, and the terrible towel gets thrown in the junk heap. But anyway, moving on to brighter things. For those of you who are not football fans, Adam is currently a professor of medicine and psychiatry. He's a chief of addiction medicine. He's boarded in medicine, addiction medicine, and preventative medicine. Author, deeply involved in the, as you know, the PARCA project, which you can see is a program of addiction research, clinical care knowledge, and advocacy, and has helped, I believe, found actually and develop the Greater Intermountain Node for research. So He is really our go-to expert here in this matter. And Adam, thank you so much for agreeing to do this. And without further ado, take it away, and then we'll hopefully have a very vibrant discussion.
Yeah, so thank you, Perry, and thank you, Reshma. And I appreciate you really killing my day talking about the Browns beating the Steelers over the weekend. It's like the worst team to beat the Steelers. So I recognize many of you on the call, and for those who don't know me, I'm really excited to present to you today. My goal really is to be provocative and to really think in the next 10 to 15 minutes about how whether medical cannabis is appropriate for a treatment of opiate use disorder. I'm going to do a little bit of background. I also, before I kind of go into the meat, it is a high-level overview because we cannot really cover all the literature in this area in a 10 to 15-minute presentation. In addition, I'm happy to help you all throughout your deliberations, not only on this issue, but throughout your deliberations throughout the year. So feel free to call on me at any time. I know many of you. I'm really excited to collaborate with all of you. You see the screen? Can you see my slides moving? Do you see my slides moving?
We can see it.
All right. So just to get things out of the way for disclosures, I don't have any fiduciary conflict of interest. A lot of the work that I've worked in marijuana and cannabis over the course of the last 20 years is from my work at both the University of Pittsburgh, the University of Utah, and the Veterans Health Administration. I do want to disclose that I do serve on boards of directors of both the American Society of Addiction Medicine, the International Society of Addiction Journal Editors, and AMERSA, which is the Association for Multidisciplinary Education, Research, Substance Use, and Addiction. I don't receive any fiduciary compensation for that voluntary service. I also want to recognize that what I'm presenting today is my own. It does not reflect the views of the VA or the University of Utah or any other institution or organization. So the central question I was asked by Reshma and Perry to talk to you about is the inquiry is whether medical cannabis is an effective and appropriate treatment for persons with opiate use disorder. And in order to really understand this very narrow question, we have to talk a little bit about the whole gamut of what opiate use is, opiate misuse, and opiate use disorder. So the definitions are really important here. And when we talk about the literature, there's a lot of fuzziness between all these definitions. First is opiate use. And we know that patients receive opioids both on a short-term and a long-term basis. It's important to recognize that use in and of itself, prescribed opioids, is not necessarily a bad thing. There's been a lot of literature, a lot of editorials and commentary about reducing opioid dose exposure, etc. But for the most part, people do require opioids. Opioids are a good pain medication, particularly in the short term. And there's been a lot of guidance since recently that long-term use should be not encouraged or discouraged. The second category of patients is what vexes a lot of primary care providers or pain providers, and that's this whole idea of opiate misuse. So if a patient has opiate misuse, you can think of someone doing aberrant behaviors, maybe escalating the dose, maybe diverting that substance, maybe getting other medications or opioids to treat their pain or treat something else. And this is such a vexing clinical conundrum for a lot of providers out there. And this is the gray area of our addiction field because these people do not necessarily mean that they have addiction. They have opiate misuse and are doing aberrant behaviors that may go to addiction, but may not necessarily have good treatment availability. So a lot of what we're doing in the United States right now for this patient population is to do opiate risk assessment and then mitigating potential harms. That may be reducing the opioid dose over time, maybe increasing monitoring, making sure that we're checking the PDMP or the DOPL program here in Utah. All these things are to try to avoid and to mitigate the risk of patients with opiate misuse. This population has a lot of problems with opioid overdoses. So patients in this category are often very at high risk for opioid overdoses. The third issue is what we're talking about today, though. The third category is those patients with addiction. And addiction is often characterized by immediately if you have illicit use of opioids like heroin or fentanyl on the streets, but also prescription opioid use can actually lead to addiction as well. And addiction is a definition that's, I'm not going to go through the definition today, but it's a 2 out of 11 criteria that people have to meet in order to meet the criteria for opiate use disorder or opiate addiction. The classic definition is that's a maladaptive pattern of use that causes harm. So patients who are doing things untoward and going out to procure heroin or craving a substance, all these things are characteristics of what an addiction is. And the gold standard treatment for this condition above any other condition, not even going to the treatment programs, not just going to counseling, not going to 12-step programs, the gold standard treatment above all else is medications. And that medications can be done with methadone or buprenorphine and naltrexone. And a big push in the United States is to try to get more access to these medications for this patient population. And it's important to recognize that overdose, especially, and you see that a lot in the cannabis and marijuana literature, can occur both in patients with opiate use, opiate misuse, and then obviously opiate use disorder. So what is the science? The science right now, and just in general, this is a recent basically report from NIDA director Nora Volkow, and where she really kind of categorized what the next wave of science is going to be with regards to addressing both overdose problems, but more importantly, the increasing rise of opiate use disorder in the United States. And it was a really nice editorial because she categorizes it to 3 different domains of science. First, this whole idea of how can we reduce overdose prevention and reversal? How can we address and initiate people into care? The second is the treatment of opiate use disorder. So that is increasing the amount of access and quality of care for patients to receive medications or new novel medications that are in development right now to treat patients with addiction or opiate use disorder. And the third category is kind of where the literature gets really fuzzy, and why this is even coming up today with you all, is that we know that cannabinoids receptors in your brain and throughout your body actually have potential for reducing pain. And there is some thought to, can we narrow the specific cannabinoid receptors and target these receptors specifically to reduce pain? And the literature right now, even through NIDA, Nora Volkow saying that, that's where the cannabinoids may be effective. They're not necessarily going to be effective for the treatment of opiate use disorder or prevention and reversal, especially with regards to overdose-related deaths. So I will say, just as a caveat, I got to say this, that we are searching for treatment for OUD. And we've had a huge problem in the United States that society and healthcare providers have not embraced the best science to treat opiate use disorder. Providers simply don't provide medications. And it's really an indictment of the healthcare system that we are searching for alternative treatments like cannabis when existing treatments work. We know that there's a lot of misunderstanding, misinformation, lack of education, preconceived notions, and even stigma of what addiction is, but more importantly, the stigma of medication treatment or treatment of opiate use disorder. I put on the bottom right here is a really nice, the National Academy of Sciences put out a nice editorial recently about how they think that the United States should go. And you can see that nothing here has to do with cannabis or alternative treatments. It's all about reforming legal requirements for buprenorphine, reduce restrictions on nurse practitioners, support innovation in methadone delivery, eliminate unnecessary burdens, and utilize collaborative care models, for example, for medication treatment. And a lot of medication treatment in the United States now is trying to be put into primary care offices, outpatient providers, to reduce the stigma of going to a treatment program, et cetera. So just want to let you all know that. In addition, you know this. So I've done a lot of work in terms of the epidemiology and medical consequences of cannabis and marijuana. You should know briefly, you know this. Cannabis is the most frequently used illicit drug worldwide. It's the most commonly illicit drug used in the United States and increasing on an annual basis. About 12% of people greater than 12 years old or older used marijuana in the last year. There's a lifetime risk of developing cannabis use disorder, approximately 9%. The best evidence is between 5 and 10%. And this is addiction. So I've actually withdrawn people from cannabis in an inpatient setting because of problems associated with their addiction to cannabis. It is consistently associated with other use, We know that if you use cannabis in an illicit fashion, you're going to have a more likelihood to use other substances like opioids, for example, or alcohol. And we know that about 1.5% of the United States has a cannabis use disorder. And we know that we increase the use of cannabis and marijuana in states with medical marijuana laws. We've actually seen this over time. It's a correlative issue, not a causative issue. But with states that have medical marijuana laws, we have increased problems associated with other substance abuse as well as cannabis. And then, by the way, if there's any questions, feel free to use the chat. I'm actually monitoring the chat as we go along. All right, so let's talk about some of the evidence. So there is, now again, this is not addiction, but we do know that cannabis can be used because of the cannabinoid receptors in the body, that there may be some benefit to pain. A recent Cochrane review, which is a group that actually reviews all the literature, indicates that the effectiveness of cannabis-based medicines for neuropathic pain was small, but may be outweighed by potential harms. And the harms associated with cannabis use exposure long-term is a huge amount of literature. We're not going to get into that today. There was a recent systematic review of 43 randomized trials that found that cannabis-based medicine may be effective for chronic pain based on living evidence, primarily for neuropathic pain. But the clinical significance is uncertain. And I want to indicate here, and we're not going to dive into the literature too extensively, but it's a good thing to think about chocolate. A lot of the literature is comparing marijuana or cannabis to nothing. Okay, so you're kind of looking at people who have cannabis versus people who have nothing. And it's similar to what you think about like with chocolate. If people with pain, if they have chocolate versus no chocolate, the people who get chocolate are probably going to be better in some aspect because they get some benefit of the chocolate. And that's kind of the literature that we have with regards to marijuana use, particularly pain. We very rarely, in fact, no good literature has compared marijuana or cannabis, medical marijuana and cannabis, to effective strategies for treatment of pain. One-on-one comparison versus evidence-based treatment, just not there. In addition, as you all know, there's a huge boon to the industry to link cannabis with pain treatment because pain is the most common patient complaint that we have. All right, so let's talk about what I was told to talk to you all about, and that is about what OUD. So can cannabis, medical marijuana, can it treat OUD? So a lot of the advocacy for this, it came out of one study. Marcus Bashhaber, actually known pretty well, did a widely published study that looked at states that have provided medical marijuana and legalized cannabis use for medical purposes compared to states that didn't through 2010. So very early on in this whole wave of policy changes of medical cannabis. Interestingly, this study was not about opiate use disorder. It was not about addiction, but basically said in states that have medical marijuana laws, there seems to be a reduction of overdose. This led to a lot of states then thinking of medical marijuana as being a potential treatment for opiate use disorder. And interestingly, Keith Humphreys out of now Palo Alto or Stanford and colleagues published a subsequent analysis that extended the exact same study through 2017 with similar methods and found that the exact opposite was true, and we'll talk about that in the next slide. In other words, those states that had medical marijuana laws compared to those that didn't, going through 2017, actually had more overdoses than those states that did not have medical marijuana laws. It's important to realize that a study of individuals showed associations with cannabis use and increased rates of non-medical use of OUD. So we see people who use medical marijuana or marijuana in general will have increased rates of opiate use and opiate use disorder. And the preponderance of the evidence is that there's no current evidence that cannabis is an effective OUD treatment. And this is particularly true because there's never been a comparison between effective treatment that we have, those medications like methadone, buprenorphine, naltrexone, that we know and love, that work, that we just don't utilize. Okay, so there's never been a head-to-head study of this. There's no evidence that it actually treats OUD or addiction-related treatment. And then one of the other studies that recently came out, this is out of in the United States, who basically looked at craving, and there was a slight association that cannabis can reduce craving of opioids. And this is actually thought to be, in the editorial that I think you all received, I thought to be maybe a helpful help in treatment of opiate withdrawal syndrome, which is a very finite 2 or 3 day period where people are withdrawing from opioids. It's not really treatment of OUD, it's really treatment of potential craving associated with withdrawal. So the study I mentioned about the extension study, this is actually the best evidence that we have currently right now. It extended the study from Buschauer down from 2010 to 2017. And even the authors of this study, Shover and Humphreys, basically said that the first study from Buschauer was really glamorized to say that as a potential treatment, but the evidence really didn't show through if you extended this through. And in fact, those states that had medical marijuana laws increased OUD and overdose-related mortality by 23%. There was no evidence in the literature that OUD is being treated effectively by medical cannabis. And I really like this quote: the claim that enacting medical cannabis laws will reduce overdose deaths should be met with a lot of skepticism. Perry mentioned the American Society of Addiction Medicine. I believe you received that. That was a recent 2020 summary of the literature associated with this evidence. And there's not a lot of evidence in OUD treatment. There is, you see in that paper that we sent you, is that there's only a paragraph of it because there's really not much out there. One of the recommendations is that healthcare professionals should not recommend cannabis use for the treatment of addiction of opiate use disorder. And importantly, because of the association in our field that we know that cannabis, medical cannabis, can cause use of other substances as well. One of the recommendations from the American Society of Addiction Medicine was that some of the finances even that we receive from medical cannabis really needs to confront cannabis use disorder and other substance use disorder treatment and prevention. So it's just recognizing that medical cannabis can cause untoward effects as well, including addiction to not only cannabis, but other substances. I gave you also this article, and I'm not going to read this through because I do want to leave some time for questions. There was a nice editorial from Roger Weiss. He's a Harvard professor, know him very well, and his associate Joji Suzuki. And it really, again, summarizes that there's really been a lot of politicizing about OUD treatment using cannabis. And it's certainly recognized that there are population-level studies that indicate cannabis use is associated with a higher risk of developing OUD. So it's actually a reverse problem. And the evidence of a lot of summary of the evidence out there is that cannabis did not affect patient outcomes, even in treatment for OUD. So there's some thought that maybe cannabis in methadone treatment or buprenorphine treatment, if you add cannabis on top of it, it improves patient outcomes. But the recent survey of the literature says that that's not even true. So not only does it not effectively treat OUD, but may incite or cause OUD. In addition, it's not a good supplemental treatment for patients who are actually in evidence-based treatment. One more slide here. The editorial again mentions that there's no prospective clinical trials, and there likely will not be prospective clinical trials in the future about this area. There will be probably some trials about cannabinoid receptors for pain, because we're targeting specific medications for specific cannabinoid receptors. But you're not going to see anything anytime soon about marijuana for the treatment of opioid use disorder. I actually talked to NIDA the other day about this. They're just not interested in this area at all. They don't think it's not a viable line of research. So as a summary, there's no data to present to support a listing of some states for OUD treatment for cannabis. The evidence actually argues exactly opposite, that actually if you provide this indication for OUD, you may actually cause more people to have opioid use disorder or problems associated with their opioids. And we certainly, as Perry mentioned just a minute ago, we have to be very careful. There's a lot of advocacy in this area, as you all know, and we have to make sure that there's science associated with it. I am really worried, and a lot of my colleagues are really worried, that medical cannabis in states that have enacted it have more problems with addiction. And I know many people on the call here have the same views. And I'm very nervous and very worried that we may have a lot more medical consequences of cannabis use, even in a medical cannabis use program. that may be deleterious for many of our Utahns. So I wanted to end up there. I apologize. I went over a little bit longer than I would do. I'm happy to answer any questions and stick on. I can also answer questions via chat. Thank you all for allowing me to today, and I'm happy to collaborate with this illustrious group in the future. Thank you.
Adam, thanks a million. No, you did not go over in the least. This was a very, very helpful review, and again, I truly appreciate your time and your expertise. I will certainly take the prerogative. Adam, typically what we've done after these presentations is ask for sort of a summary that with a recommendation that could be then voted on as a way of memorializing our thoughts as a board, because we are asked on a regular basis by the legislature to determine whether there should be any additional indications or restrictions, and we want to do this in the most evidence-based way and responsible way we can. With your permission, Adam, and to save you time, because I think you've already expended enough in this, I will just be happy to take a summary of the studies that you provided and the recommendations from ASAM, and put those into sort of a simple paragraph with a recommendation that we as a board can then vote to approve as going forward. And basically the logical conclusion here is just exactly what ASAM is stating, which is there's really no scientific basis to recommend. And in fact, there's some concerns and considerations. So I will do that, and we can then put that before the board next month. If there's anybody who wants to see that in advance, we'll send it out in advance for your, and so we can wordsmith it a bit. But I'll volunteer to do that bit of a work. I'm very good. I'm very good at.
I'm happy to help you with that if you want. I'm happy. I apologize. I don't know if that was my task today to put something forward to you, but I'm happy to help out in that process. I think we just have to be very. One of the problems, as I mentioned, is this whole idea of use, misuse, and addiction. And the key thing is that we really need to hammer home that OUD treatment is not effective using medical cannabis. We just don't have the literature and science in that. So. Right. So I'm happy to craft a paragraph or help you craft a paragraph for you all consideration. Thanks.
Okay. Well, your name will be used in the most respectful terms as the person who presented the data, and your qualifications do so. And so I'll share that with you. But I just didn't want to overburden you with work. I'm very good at giving homework to the group. I feel responsible for accepting some as well. So I'll go ahead and take that on my shoulders, and then we'll make sure it passes muster. So with that said, any thoughts, discussion for Dr. Gordon?
Call me Adam. My patients call me Adam, so please feel free.
This is Ed Red. I just want to tell you guys what happened back when we were considering medical cannabis in Utah. The argument about the opioid overdose death rates in states that legalized cannabis for medical use was really promoted heavily to the legislature as a reason to, all these people are dying because we don't have medical cannabis available and we can reduce the death rates. And the data from 2017 are really, to me, overwhelming. Do you know if there's any data that tell us why? I mean, the opioid overdose death rates go up in states. Is there any? I mean, it's an association, obviously. We don't know if there's causation or not. But the question is, do people who use medical cannabis go off their Suboxone and their methadone, or what, or their Vivitrol? What happens exactly?
Yeah, thank you for that question, Dr. Red. That's a very, very. We could spend hours talking about this. I'll give you some thoughts. First off, when you have permissive statutes and regulations for medical cannabis, you have a kind of an implicit thought that cannabis is actually a medicinal treatment, right? And so therefore you have more people that say, even though they're not doing medical cannabis, marijuana may be fine, especially youth and young adults who say, hey, where's medical marijuana? I just use marijuana on the street, it's fine. And so there's some thought that the regulations or rules of medical cannabis can actually make a permissive culture of more people using cannabis overall. And we know that people who use one illicit substance are more likely to use other illicit substances. So it may not necessarily be the people receiving medical cannabis. It may be other people out there that are just now using because of the permissive culture.
Got it. Okay.
Probably the biggest. Now, this is all observational data. There's no causal data here for that. So, but but the causal data, the correlative data that push this is the same problem, right? So it's not. It's really more of a cultural issue.
Okay. Thank you.
And I think there's a lot of literature about cannabinoids, and we could go into that literature really extensively. The pain people would be much better than even I would, but there are specific targets that a lot of researchers and a lot of companies are looking for with regards to treatment of pain. And that's where, as I mentioned that neurovocal slide, that's where NIDA and NIH and all the stakeholders say that's where we should go, treatment of pain. But there's absolutely no evidence, none, that says that cannabis can effectively treat opioid disorders. And that's the important point here. Don't conflate pain and don't conflate overdose with treatment of addiction, because it's totally different.
Adam, I just wanted to thank you that was a remarkably well done presentation, concise and loaded with good information. As a psychiatrist, I have been asking that question that Dr. Red asked as well. And I'm a psychiatrist, so I see everything through that lens, but I think this association and potential causation, but certain association in other states with higher rates of addiction and higher rates of overdose, when there is that kind of cultural acceptance and medical endorsement of cannabis, it's kind of the double whammy. I think it speaks to the harms that regular use of cannabis in developing brains causes. And I think that then backs me up to what Perry's saying is these decisions have to be clinically driven. Has to speed, access, rushing things in order to improve access doesn't let us off the hook for speaking clinical truth. And, as always, if there are decisions kind of that need to be made quickly, you make no decision until you have the clinical kind of facts established. So I just feel this is so perfect timing. This is so important for us. We know how the legislative season works. The more support that some of these potential bills have, that they're going to be put in the front of the session. There's going to be a lot of really slick and effective advocacy for these things, and it will gloss over the clinical. So I think, Adam, it would be great to have your assistance even in our next session, because the next most common thing that medical cannabis cards are used for is PTSD, and a little grayer area, but similar problems, and very little kind of concise, factual based information such as what Adam presented to us is out there. And I think it has more to do with the clinical side. We're poor marketers of our products.
So thank you, Dr. Carlson. Thank you, Katie. That was great. I will say, and I put a slide in there, the presentation. Feel free to disseminate that slide anywhere or put it on their website, whatever. It really also is an indictment of our treatment program, our treatment algorithms, and for OUD, for opiate addiction, in that a lot of people are reaching, hey, I don't have access to good treatment, or I don't have access to, I don't want to go to a drug and alcohol treatment program, or I don't want to be on medication treatment. So they just search for anything else. And so you're going to have a lot of patients who are basically going to be advocates to say, hey, why not can I use marijuana for my treatment of opioid use disorder? Because they've never really been touched with good access to good quality of care for opioid use disorder. And so I think the indictment here is not misinformation. It's really misinformation about the treatment of opioid use disorder. That's bigger than your board can do, but it really is an indictment of our system of addiction treatment in the United States. And we need to provide more humane and more patient-centric approaches to addiction for opiate use disorder. And I think that's a lot of my research is about how to integrate within primary care. Stuff like that will actually help reduce the searching for something else, whether it be kratom, whether it be cannabis, whether it be other things. Those are things that we have to address. It's a bigger problem than just cannabis. I'm happy to be on for a while. I'm happy to answer any things in the chat. I know that you have a busy agenda today. I want to thank you all for participating. Perry, I'm able to hang on if you want me to, or otherwise I can say goodbye.
Well, Adam, I think what we'll do is without any other questions I see coming up, I think we'll move on to the next topic, which actually is back into Katie Carlson's court, where we're just going to quickly get her summary points of view on a review talking about the use of medical cannabis for mental health disorders. And then we're going to look at sort of our conclusory comments with regards to the consideration of indications for anxiety that Dr. Crookston presented last month. And it'll probably be a quick vote because we've already done a lot of wordsmithing on that. These are areas that may pertain to your interests, and so you're welcome to stay on and listen in and weigh in on some of this if you'd like. Your expertise is welcome, but I don't want to capture you more than you already did. And if you do check out, I'll send you sort of my attempt at a very brief summary, concise, not brief, but concise summary of your conclusions and what we may then bring before the board next month to vote on in terms of any thoughts with regards to where the board might stand on the use of cannabis and the medical cannabis program here in Utah with regards to opioid use disorder specifically.
This is Ed Red. Just really briefly, Richard and Mark, are you aware of any legislation that's going to try and expand the indications for medical cannabis in Utah? Is the opioid use disorder been brought up as possible legislative action type things, or what's going on there?
No, nothing suggesting adding new conditions so far.
Okay. All right.
I think lawmakers that have asked questions, and when they ask questions, we always try to be helpful. One of those questions that came up just recently was use of cannabis to treat substance use disorder. And I think the discussion today in the presentation, I think will be informative to those legislators that are just generally considering the idea. I think naturally when they get questions from constituents, right, they want to learn more. And I think that's what's happening is they ask questions, and that's healthy.
Yeah, Reshma, I don't know if you want to speak to the question that came to you or if that was through Rich. I know, but Reshma, this I know somebody's.
My phone, sorry about that. My phone went off. Sorry, but it's connected to my computer. Went off. Sorry about that. Okay.
Reshma, do you want to just talk briefly about how this came around as a point of interest?
It was a while ago, so it's going.
It from
I can't remember.
Generally, there was a legislator that contacted us about it, and then I contacted Reshma about it. Yeah. So I think what we can do is we can share some of the information that was shared during this meeting with some of those lawmakers so they can understand the issue better. And, I think it's important that we engage in a conversation with them, and they're just asking questions about it. And we said that we would bring it to the cannabinoid product board, and I'm really glad that the board had a chance to discuss it today and for Adam to share his study research on it.
One more suggestion, just briefly. If you guys are aware of any, Richard and Mark, if you're aware of any potential legislation that the Cannabinoid Product Board might be able to weigh in on as a board, I think we need to kind of stay really on our toes on this whole issue because of how fast things happen during the session. I can tell you right now that a lot of legislators are not going to know very much about these issues, and they're going to rely on our opinion if we give it to them. If we don't do anything, then they'll have nothing to rely on except whatever other people say, which may not be that helpful. So I just think it's important to keep us in the loop if there's something going on in the legislative session regarding this issue that we might be able to weigh in on formally. Just a suggestion.
Sure.
Yeah, no, right. So that's right, Ed. My view is that we ought to be proactive and try and get ahead of the curve rather than always being reactive. It's harder to change things once they are in place rather than to inform, as you've stated. So that's sort of the role I think we've taken on in reviewing these. So that's why this month we quickly put Adam in place, and then Ed will get back to other issues with other indications next month and the month after. There was another issue just very briefly that came to my attention through Reshma with regards to some interest in apparently once again from it's more from the populist, if you will, approach towards this, which is medical cannabis in one form or another in suppository form, which is really interesting. I know in having studied in France myself, the French seem to have a proclivity towards suppositories. Americans have not. Go figure. Cultural differences. I'm not going to jump to any conclusions there, but it's really generally not a delivery form that Americans have embraced much, other than for purely topical reasons having to do with that part of the anatomy, but not for either beneficial pharmacology necessarily. And yet, if this is a populist issue, I thought we should get on top of this early. And I don't know if Karen, if Reshma has addressed you yet, but I thought somebody in your department might do a little research on, rectal administration and rectal delivery and all the issues, the caveats around that. So we'll get to these sorts of things later. But all this to say, we're trying to stay one step ahead and really use this board as a scientific advisory board to the greatest extent we can. And I think that's just our responsibility, and I take that seriously. I know you all do too, so we'll continue to do that. With that said, Karen, do you want? Yeah, please.
Yeah, I just need to hop off for another meeting, I'm afraid. Did you raise that issue and directly address me? I wanted to just make a comment. So we're happy to try to find a PharmD student to do that. I did see Reshma's email. Thank you, Reshma. Sorry, I just responded a few moments ago to that. We'll give it a whirl and see if we can find someone interested in that. I will just take a little bit of issue in the epilepsy world. Rectal diazepam is actually used quite frequently as a rescue medication for status epilepticus, but wide use and wide acceptance. But yeah, we'll have to kind of see what is known. I had no idea that this was even a thing. So, it was interesting to get that email.
Yeah, well, and thank you for that. Thank you for that correction. That's, again, this is why we need to bring it, because none of us can begin to be expert in all areas. So I'm going to try and direct some of these inquiries to those areas of interest we have, and we don't have. If we're limited, then we'll reach outside of our group and bring people in like we have with Adam. So Katie, do you want to sort of summarize the thoughts and considerations from that review that you brought to us with regards to medical cannabis and mental health?
Yes, I do. I looked at, I wasn't sure if we were going back to our last meeting where Mike and I had prepared information on anxiety and cannabis, as well as PTSD and cannabis. I then looked at the BMC article that Reshma sent around. And so I'll start with the end, which was that. And I hadn't looked at that before our last meeting, but it didn't really change anything. That review article reinforced the concept that brain regions involved in memory learning and fear processing are impacted by THC and combination THC CBD products, and further studies are needed to determine safety and efficacy, of the use of these agents in patients with PTSD. So the authors of that article that Reshma sent around, which was a review article, I think it looked at 22 studies. They didn't find conclusive evidence that would change our recommendation from last week that PTSD should not be added to the list of qualifying conditions to be treated by products from cannabis dispensaries. So I think that just, I'm basically saying no change. And, you know, I think in the chat box, there's a lot of discussion about kind of lack of appropriate evidence, and we love randomized clinical trials. We think they speak better than ourselves. But I agree that we probably can't wait for that. I mean, there are efforts in the PTSD realm to get better data, you know, and I'd say it's speeding up, but it's not going to be helpful this legislative season or next probably. But we have enough data within Utah and out there that maybe we could present and look at, because with PTSD, unlike opioid use disorder, I think there's some agreement in the controversy around, you know, state to state. With PTSD, every single state that has medical marijuana PTSD is a qualifying condition. Every single state. And, you know, we're swimming upriver, but I stand by that conclusion that I drew by looking at what I could. I mean, I think you all know I don't have the resources. I don't have this expertise or skill that could put together, you know, maybe what we need, but I can just tell you there's no evidence for this. There's some suggestion that we need to get better evidence, and there's certainly relevance for the cannabinoid or the endocannabinoid system in PTSD. And but it's just not, we don't have it. We're not sitting on a body of evidence that says anything about the efficacy, and we are sitting on evidence that speaks to the safety. And that loops me back to Mike's presentation, you know. So that might not be what you were looking for. I apologize. I thought I was just looking at that BMC article and just kind of seeing if that would change anything. And
I appreciate that, Katie. And I was just sort of looking to you with your expertise to sort of, you know, create a summary as you did. The conundrum I think we face, and I look to Mark and Rich now as more of our direct connections to the legislature, and the bill that it currently exists and our place in it. You know, the conundrum is, and I think if I remember the minutes reflect the question I asked you last time, Katie, that if we could go back in time and we were actually asked to review indications and qualifying conditions before any of this found its way in, would we have said anything different about PTSD, recognizing at this point, right after chronic pain, PTSD is the second leading, you know, qualifying condition or indication. And then the answer was based upon your review and our then thoughts about the review in the literature, and then this BMC article that came out and that Reshma was able to find afterwards. It only deepened sort of our conviction that there is really a paucity of evidence that's favorable and greater caution and concern that would weigh against saying that, other than in very specific circumstances, under very structured conditions, by people with expertise in the management of PTSD, should sort of an open invitation to a medical cannabis pharmacy be given. So I don't know, Rich, Mark, Ed, you commented a lot about this last time as well. How do we deal with this conundrum as a medical product board? How do we meet our responsibilities, given that we can't go back in time?
Well, so the board's charge is to advise the legislature. You can advise the legislature on conditions that you think should be added. You can advise them on things that should be withdrawn. You can advise them on things that should be treated with an additional level of caution, for example. So you know, it's just interesting. I mean, I'm going to make just a social commentary for a minute. We're in a society that doesn't necessarily believe in science, does not accept science. If you just saw what happened at the Capitol not too long ago, you understand people are really proud to act on rumors and falsehoods. And so we're dealing with the same thing. You know, when people have strong anecdotal evidence, when people as a group have this group think that they're convinced that something is right, they take action. And we've seen that in the worst instances recently. So that's been going on in this country for quite a while now. So scientific evidence is fine for those of us who were taught that way, but we have to accept the fact that the majority of the population doesn't understand that and doesn't necessarily agree with that. Nevertheless, it is perfectly appropriate for this board to come to conclusions that they would like to advise the legislature on things to be added, to be withdrawn, or perhaps be treated with caution. I think, I mean, I'm going to go out on a limb right now and say, we're going to talk about the next time about this LMP, limited medical provider. And one of the issues is the education that's required for things. I'm going to propose you might want to consider, do you think an LMP should be allowed to use all the qualifying conditions? Or do you think maybe some of these conditions shouldn't be available to an LMP? Now, I mean, I definitely would keep chronic pain on there. That's the number one thing. And benefit, but maybe some of these things like, you know, PTSD, for example, I don't know. But then you think that you would say, let's say, you know, I think you do the LMP, I understand why you do it. Here's the education things you ought to include. Here's the conditions we think they should be allowed to recommend for it. I'm out on a limb when I say that hasn't been discussed before, but anyway, that's a long answer to your question.
No, thank you. And then Rich, I'd like you to wait. Ed, can you put your device on mute for a second? Thank you. And then I'll get to you after Rich.
Yeah, so I think science is one of many factors I think that legislators consider when determining medical cannabis legislation. And I think as they evaluated what legislation they wanted to move forward with, we all understand it was a compromise. And there was Prop 2, and then there was an amendments that happened after Prop 2. Prop 2 would have been a bigger, expansive list of conditions. And then it was amended and modified to be what we see today in the law. So I just emphasize science is one factor. It's not the only factor. I think it's important that the Cannabinoid Product Board and the department not think that no one's listening. I think lawmakers are listening and want to hear what some of the thoughts of the Cannabinoid Product Board and the department are on specific issues, on if certain conditions should be added, or that's the purpose of one of the purposes of the Cannabinoid Product Board. So they want to hear what the opinions are of the board as a group, and as individuals, you're always welcome to contact individual lawmakers as they consider issues. And within the legislature, there's a wide variety of opinions, right? They don't all think the same, of course. So there are some legislators that really want something that would pare it down, and others want something more expansive, and then they compromise. So those are some of my thoughts.
Sorry, quick question from a process standpoint. You know, I think obviously we have more influence when we speak as a board and we follow our sort of parliamentary procedures as a board rather than, and to reach out to individual legislators is probably not particularly helpful unless they are specifically asking us to work through them, like Senator Vickers, who has a leadership role, or if somebody asks us a specific question. I don't think we're meant to be a lobbying group in that way per se. However, from a process, I think it is very important that we meet our responsibilities. We take the bill seriously, that we have a role in it. We've been given a charge. With that, Rich, since you're the head of the whole program, when we, for instance, when we come to our conclusions about a specific indication, for instance, if we model a statement that says extra caution should be taken with regards to recommending medical cannabis for PTSD because a review of the literature shows, and then we, give the reasons for that. How do we present that, package that So it does have the respect, if you will, the potency of the thoughtful consideration of this board on behalf of the public health. Who does that get delivered to? How is that message delivered?
I think one way to do that would be to Reshma could help as a support that and draft it, put it together, and draft it in a way that is reflective of the opinions of the board together. And then we would then, I think a good next step would be to send it to the Health and Human Services Legislative Committee. And they are the committee that would review all the medical cannabis legislation. And with that, it could also be sent to some of the primary sponsors of the legislation, which is expected to be Senator Vickers and Representative Ward.
Okay, that's very helpful. So with that, Reshma, if you would be so willing, if you could sort of collect the thoughts from today's discussion with regards to PTSD in particular, with the extra cautionary note that that not only is there no ample evidence in support of it, there are serious and significant concerns, and if recommenders really should have specific expertise in the management of this population, and be in a position to monitor their outcomes very closely, something of that nature. And then maybe work with Katie and Rich, and Mark, and myself, to circulate this and package it. And then let's draw some, sort of tie a bow around it next February meeting. Same with the opioid use disorder, which I'll frame in that same sort of a way. And then I think we've meted out our responsibilities, as Katie said, and we're acting in the best interest of science and the public health. Sound okay with you, Rich, Mark, Ed, all those who have sort of talked and thought about and discussed this? And then in the sort of interim meeting, we've agreed to try and schedule the next 10, 14 days. I think Mark will take up your point a little more seriously and deeply at that point about what our recommendations might be as a cannabis product board with regards to the limited medical provider and the spectrum of qualifying conditions and indications and the level of expertise that would be expected to be able to responsibly manage those patients around the construct of medical cannabis. All right?
What I'm hoping, just so everybody knows, what I'm hoping is that by that time, there will be a copy of the legislation that will be made public. And so we can, the board could express their opinion about a specific bill that's been drafted. Because right now, these are ideas that are being drafted, right? And so it's really helpful if there's a specific bill, we can say, hey, medical cannabis amendments bill, here's some things the board would like to comment on regarding that bill. Great.
Perfect. Thanks, Rich. All righty. Let's now move to the whereas statements. Mike Crookson's brilliant parliamentary. I know you're not a lawyer and don't play one on TV, Mike, but boy, those whereases sure sounded spiffy to me.
Well, those weren't my idea. I'm the farthest thing from an attorney. That was Mark's contribution, and I agreed with him.
All righty. Are we ready to? Does anybody have any additional thoughts? Wordsmithing. I think they've been around the bend a few times now. So to my eye, they really did reflect comprehensively but succinctly Dr. Crookson's generous review of and presentation. And thank you, Mark, for, again, I know you put a lot of work into this. I just wanted to give Dr. Crookson a little bit of a forensic tap on the shoulder there. All righty. So would anybody like to put forth a motion to accept the whereas and therefore conclusion statements as the sort of official position of the the cannabinoid product board with regards to the condition of anxiety?
And I second.
So moved.
Okay. Any all in favor? Aye. Any opposed? Hearing none, this has been apparently unanimously approved. Thank you for all your very good work. Wow, we packed a lot into an hour and a quarter today. It's amazing. We're getting good at the Zoom stuff, although I can't wait until we're all, has everybody been has anybody had at least one shot yet? I've had my first vaccine. I'm waiting for, Ed's had 2. I've got 3 weeks to go now until number 2. And then I'll be armed and dangerous again for in-person encounters.
Remember public comment, Perry.
Yeah, we'll get there in a second. I just wanted to catch our breath. We're way ahead of schedule, and I just simply want to appreciate everybody's great work in getting all this through. So we're gonna get to public comment now, as I'm always thankfully reminded by my good friend and colleague, Dr. Bavitz, because I tend to forget things. So the floor is open to public comment and any additional thoughts by the board.
Oh, Kevin.
Yeah, this is Kevin Baumgartner from the Utah Cannabis Pharmacists Association. In all these meetings, I keep hearing about, we need more data, we need more data. A couple of times we've come to you guys. We've got thousands and thousands of patients we meet with every single day. We're trying to collect that data. How is the best way for me or our association to get all that data to you for review, so that then we can get more, a more complete picture?
Thank you, Kevin. That's very thoughtful and generous of you. I'm going to turn to our epidemiologist, Reshma Arrington, because, there's a lot of potential value in this data, how that data is analyzed and how it's sourced, and is, of course, everything in terms of the credibility, and we don't want to either waste your time or come to wrong conclusions. So this is a discussion, Kevin, we've been having on a regular basis about how can we be adequately resourced. We've had discussions with some of our colleagues at the University of Utah who have some skill and expertise in crunching data and taking this and maybe reshaping it to make it more prospective, so that in fact it can be of greater value. But Reshma, let me turn to you and see where do we stand with this as a process.
Yeah, I think, Kevin, that you do have my email. It'd be good to just discuss what that data looks like. And then we could kind of go from there. We have either we can look at it, or we could go through some of the groups that Perry has discussed. But if you wouldn't mind just emailing me, and we could try to set up a time to talk about that data, that'd be helpful.
Okay, perfect. Yeah, I'll get with you. Thank you.
Great, thanks, guys.
I think it'd be important for when they meet, Reshma can give some pointers on how you properly collect data, because having data is not the same as having data. I mean, how you collect it, what the questions are, and how you put it together is really important. And Reshma can offer some suggestions when she looks at what they have.
And along that same line, I think it'd be important to have a uniform, if you're going to collect the data, you need to have some sort of uniform way of doing it, so that people are asking the same questions, and, or at least to me, it's like, if there's thousands of patients using this and we want to collect data, we better have some uniform process of collecting the information. It's not going to be very helpful at all. It's just.
Right. And that's why I thought, filtering this through Reshma as a first pass filter, as it were, would be the way to go. Reshma also did, speaking of that, Ed, Mark, Reshma then did pass around the survey for additional data and thoughts about collection and uniform approaches. I submitted a lot of comments about that. And Reshma, when would be, and I trust, Rich, that you and Reshma are now working together to sort of reshape how that survey is going to go. And when Reshma, when you and Kevin interact, that would be a good opportunity to get some obviously other thoughts and look at what people are saying, what that data, what those that data set looks like and how it was collected. So again, I think this would be Reshma, maybe you can give us a bit of a report on that. Let's see, at February's meeting, we're going to have, let's see, Ed, are you going to be presenting So we're gonna have a presentation. So
Yeah,
I think
we've been talking about autism, and along the same lines, we've been talking about opioid use disorder and, you know, PTSD
Right.
and things like that. Same kind of concepts, the same, you know, hopefully information, whatever information we have or don't have is what we're going to talk about.
okay. So February's meeting, we're going to talk about autism with Ed giving a presentation. We'll summarize where we are with regards to these legislative issues and follow up on whatever comes about in the next week or two's meeting that we we'll talk about the limited medical provider issues and all that. And then maybe what we'll have is a sort of a summary of where things stand with the survey and this data analysis issue, Reshma. And that would be, I think, 3 very meaty topics and enough to consume us for February. And then we'll see what remains for March and thereafter with assigning some of the other qualifying conditions and all for review. Any other public comments at the current time? Any additional thoughts from the board? Any pressing matters? I always sort of points of angst that have bubbled up with regards to your roles or these issues. Okay, then we're all at peace. That's great. All right, well, we'll call a motion to adjourn then.
Motion adjourned.
And second.
Second.
And hearing no opposition, we accept ourselves as adjourned. All right, have a wonderful rest of the month. Stay safe and well, and see you soon, I hope. Bye-bye.